Hi, everybody. Alex Borzak here, Doctor of Nursing Practice student for Widener University. We're starting module number 3 of our exploration into transitions of care programs. This module is going to look at the building of a program from scratch in developing into an evidence-based standard that can be implemented into a practice or clinic to start utilizing transitions of care as another service line and as a mechanism to start decreasing the readmission rate and emergency department utilization rate for their patient panels. So before we can even begin to talk about the different components of a transitions of care program in great detail, we need to figure out what exactly is a transitions of care program and is it actually beneficial to use? We've already kind of talked about what a transitions of care program is in an earlier module. So our focus here is going to be, can it be used to reduce the number of moderate and high complexity patients within 30 days to prevent 30-day readmissions and emergency department visits in a cost-effective manner when you compare it to usual care? So I did do a literature review utilizing the JBI, Joanna Briggs Institute method of evaluation and leveling of the evidence that has been published, and took 1,095 records that were identified through various bases, including PubMed, CINAHL, EBSCOhost, all that, as well as search through the gray literature as well. Ultimately, 36 studies were included in the formal review, and then 33 of those 36 were actually utilized to develop this evidence-based practice standard that we're going to keep talking about. So this is just a review of the different types of interventions that have been used as part of a transitions of care program. And the whole goal here is to kind of summarize all these different interventions and look at the positives, pros, and cons of them, the outcomes, were they beneficial, were they not? And for the most part, these interventions were beneficial. A couple of interesting points here that in particular, the post-discharge phone call, the follow-up phone call within 1 to 2 days after discharge from the hospital or the emergency department, it was about 50-50, depending on the context of how the phone call was applied. If it was followed strictly using the CMS guidelines of just following up with the patient and checking in with them, it wasn't very effective. However, if it was used to identify barriers that would prevent the patient from attending the appointment, the follow-up appointment on the outpatient side, and to address for any initial concerns immediately post-discharge, it was actually very beneficial as part of that continuum of outpatient care to reduce readmissions to the emergency room and to the hospital. Same thing with a nurse navigator or community navigator. The findings were kind of skewed a little bit depending on patient complexity. However, overall, as long as there was an individual that provided those services, the outcomes were very positive as far as preventing repeat readmissions or ED visits within 30 days of discharge. One study that was very interesting showed that there is a ceiling as well as far as risk stratification. Patients with a LACE score of 13 or higher, particularly patients with congestive heart failure, did not respond to TCM interventions in that study, although they were very passive in their application. It does bring up a good point, and something for consideration, though, is that patients with a very high LACE score might be too complex to drive any benefit from proactive or active interventions aimed at reducing readmission or optimizing treatment. Instead, though, you may need to consider more palliative or interventions that are more focused on relieving symptoms rather than reducing exacerbation or reducing preventing progression or slowing progression of the disease. They might have just hit that ceiling where no other active intervention is going to work, and palliative considerations need to be taken, or supportive care scenarios need to be considered at that point within treatment if the goal is to reduce readmissions, reduce hospital visitations. Other areas that were reviewed include clinical pharmacists, and that was very highly viewed as a very good intervention to be utilized that had a lot of positive outcomes in terms of reduction in hospitalizations and reducing the odds of readmissions and stuff of that nature as well. Additionally, the research looked at different components of the transitions of care team and the impact of whether you need a community navigator like a social worker or an LPN or RN to utilize as a community navigator, or even looking at advanced practice providers versus physicians, who's in the component. And really, the literature didn't show a preference over one type of person over another. The big thing is to follow ACMA standards is they needed to have the level and scope of practice in order to satisfy that standard for that particular thing. So you could use navigators, you could use LPNs as like your community navigators. You could use LPNs to do risk stratification, at least collect the data, but to actually make a decision, you need somebody at least with an RN scope of practice, if not like an APP or even a physician. So there are different ways that you can go about compiling your team as well to administer your transitions of care program that speak to the cost-effective nature of it, but still meet the goals, and you can still bill for those different aspects as well. Continue on through with same things. So their reduction of admissions ranged anywhere from 20% up to 44%, depending on what type of intervention and what combination of interventions were used. One of the biggest things to reduce readmission was risk stratification. Pretty much unanimous result in the literature that was reviewed was that if you can get risk stratification and identification of your patients right, everything else follows through, and you're going to have a very effective program at reducing readmissions, and also very effective program regarding the cost benefit side of things as well. Ultimately, risk stratification methods that utilized machine learning were the optimum or gold standard, because you can use data from multiple databases simultaneously. The process is automized, and it can be very sensitive and very specific to identifying patients that would benefit from transitions of care services. However, you can use different tools that are out there that are more manual, such as the LACE score or Charleston Comorbidity Index or HCC scoring. Those all performed really pretty much equally. There's no clinical significance that defines one over the other. The big determinant about which one you want to use is what information is readily available to you, the provider, if you're going to be the one performing risk stratification, or what information is available to the person that is doing your chart abstraction and doing the risk stratification at that step of the process. So what is most convenient and affordable to your practice is the one really that's going to be best for you to use individually in your flow. also what else you can afford. Interestingly enough, though, that the literature did also say that the combination of risk stratification and provider adjudication was superior compared to just utilizing a risk stratification score on its own or just using provider adjudication on its own. So that's something else to consider as well. As far as the cost benefit analysis goes, that these programs do provide better financial incentives compared to usual care. And a lot of this, again, we kind of talked about this in module 2, is that the most cost effectiveness is going to come from cost avoidance rather than the billing charges that are associated with transitions of care. That doesn't mean that you can't bill for services specifically under the transition of the care. You can, and that's going to help with subsidizing the service line and things like that. But the biggest advantage to having the service line is through cost avoidance. And practices report up to $3,700 of cost savings through cost avoidance. And the percentage spending reduction goes up to 44%, minimum being like 22% of spending reduction. What's interesting here as well is that the higher deciles of costs, so the higher areas where you're spending the most on your patients, those types of patients is where you see the most reduction of spending, which makes sense because that's where you're putting the most resources and spending into that patient type. So you can see the most, you're going to see the most savings in that realm because you're putting the most amount of money into it. So that is just one space, one part of utilizing this whole components, looking at all of the components that go into a functional transition of care program. So return on investment is one, patient retention, satisfaction, staff satisfaction, the cost to the program to have this service line as part of your practice, but also the cost to society. The other cost is going to be in other areas that you need to consider are the people that you're going to involve in this program, the processes that you're utilizing, your referrals, your appointment time and type of appointment length, practice workflow that your service line is going to need to fit into, the stakeholders that need to be involved. Again, looking at the 7 essentials, it's a cross continuum of care that is involved. So from the hospital to the clinic to the specialist and back again, everybody is involved in making sure of utilizing this process efficiently and also getting benefit of utilizing this process. Your client recruitment and management, again, goal setting, risk stratification. Are you going to open the service line up to practices that are outside of your network so that they can take advantage of this and that you can also take advantage of billing as well? Technology, how are you utilizing technology in this? Through your documentation, your EHRs, your data transfer, and information transfer, reliability in leveraging it for patient contact. Are you going to be able to utilize video conferencing or teleservices? And also, how is your EHR integrated as far as like patient being able to access all of this information on their own outside of the appointment time? So these are all things that you need to consider and look at as you're formulating your program for your practice, and also as you are looking at other aspects of what you have available right now, and are they efficient and can they be easily plugged into this new service line? So this is the Ottawa model of evidence-based practice, and this is what I use to pull in all of those different components of not just what we need to consider, but also how we're going to intervene and how we're going to transition all of these different things into this service line to make it an actual functional process and program within the practice. So the Ottawa model divides everything into 3 different segments. So assessment, monitoring, and then the evaluation. So we look at what is there and what we need to use, the transfer strategies, how are we going to implement this, and then what outcomes are we looking at, and then how are we going to evaluate those outcomes to see whether or not this has been successful program, but also successful implementation. So within the practice environment, we'll look at the assessment. What kind of components do we need to consider as part of the developing, and what things we need to include in the structural and the overall process of the project. So the structural components, we need to look at the health record, the gap and thematic analysis. So what we're looking at here is, where are the gaps in the current model that is being utilized by the clinic, and what kind of themes are developing through the gaps and through the staff and patient attitudes? What's the flow of the appointment presently, and how is this going to fit into the model of the transitions of care program, as well as what is the abstraction process? How are we gathering and summarizing the data so that it can be used efficiently during the appointment time? Social aspects, staff satisfaction and present knowledge of the transitions of care program, and also just the overall function of the patient-centered medical home. Additionally, patient satisfaction with present care is important, because if the patients don't see the value of the transitions of care program, this isn't going to increase compliance. It's not going to change compliance. It's not going to change patient behavior as well. So that's an important factor to do. And this all also gets incorporated within potential adopters about the staff knowledge and patient knowledge and attitudes as well. Skill comes in to the program where you need to be able to risk stratify patients accurately and consistently in order that to get the patients that really need these services to the services, and you don't get a lot of patients that don't need the services and you're not utilizing your resources adequately enough. In order to put these together, in order to organize them and implement them, the translational processes that were chosen to be used for this project include IHI's Plan, Do, Study, Act model, the Iowa model, and the Kirkpatrick model. The PDSD, the Plan, Do, Study, Act, is going to be utilized for the implementation to continually reassess the parts that were implemented and to make sure that they are working effectively and how they're supposed to be, and to quickly make adjustments. The Iowa model dictates this overall process of information gathering and fitting together all of the different pieces that were obtained during the literature review. And the Kirkpatrick model is a evidence-based method for evaluating the education component of the implementation to make sure that the education to the staff and to the patients has been effective, and that you can anticipate behavior change and compliance with the new procedures and interventions, particularly risk stratification, that's going to be part of this implementation. Innovation with this program is the way that risk stratification is done and applied, proactive nature of the referral process for care management and patient navigation, rather than the present model of a reactive approach to patients' visits and referral at this time that's present in the practice. Then also the other innovative part of this is the predictive cost benefit analysis. So we can show upfront that this service line can make money, that we can identify any processes that are inefficient as well, and make adjustments to maximize the profit that can be made from this service line to the clinic through billing, and also through process optimization, and therefore cost avoidance as well from inefficient processes. Transfer strategy, so diffusion, how to diffuse this information, how to diffuse and make this a transparent process, using study done by Eldinia et al., which looked at processes within the patient-centered medical home, as far as the political and social context of how these centers typically operate, dissemination, effectiveness of the dissemination will be done utilizing the Kirkpatrick model again, and then the implementation of this will be used by the Iowa model, by gathering and the construction of the evidence-based practice model, and then the on-the-grounds reevaluation and adjustment will be done using the Plan, Do, Study, Act model. Adoption, again, the Plan, Do, Study, Act model, but then also the ACMA has put together several inventories that can be used to evaluate and look at different aspects of the process, really kind of condenses different salient points relating to each of the 5 standards that they have put together, to make sure that you're gathering all of the different information components that are necessary to meet those standards and to meet those metrics that have been identified. And then finally, the outcomes we want to look at and see if we have actually been able to decrease usage of the hospital and emergency department. We have increased satisfaction between both patient and practitioner with the services that are being provided, that they're appropriate, specifically to the practitioner, that we are retrieving medical records consistently, that we have consistent attendance to the appointments with the patients. And then also from the economic standpoint, are we able to actually capture those costs, reduce them, and to increase the profits from charges and cost avoidance that we predicted using a predictive cost benefit model, decrease overall cost expenditure, and then also look at have we increased avenues for reimbursement through the service line as well. So this is the Iowa model. This is what we're using to develop our EBP practice standards. So again, this is just taking a look at the literature that we've done, the review of the literature using the JBI process, and using that literature and developing that into an evidence-based practice standard. So looking at the components, looking at our fishbone diagram, looking at our gap and thematic analysis, and putting together the standard. So we've selected a topic already. We formed a team between the clinic staff and the college. We've retrieved the evidence. We've graded the evidence. So now what we need to do is we need to develop the EBP standard, and we'll continue to look at that throughout this presentation. One of the other evidence-based models that we're going to be utilizing with this is going to be the Kirkpatrick model. Again, this is going to be how we evaluate the education arm of the implementation. So we've looked at the staff and patient satisfaction and knowledge of the patients and staff, and looked at, again, compared to our gap analysis and our thematic analysis, looked at where we need to provide more education and how we need to disseminate the information regarding this program to staff and patients. And then we're going to utilize that as utilize the IHIA rapid cycle change process to evaluate and enhance the education. And then ultimately, again, we want to see improved efficiency, what we want to see, but we also want to see retention of the information that has been provided, and also see a change in practice related to the information that was provided, giving the staff a much more in-depth base and reasoning of why we're doing these changes and what the expected outcomes of these changes are going to be. The rapid cycle process change model, again, so this is what we're going to use when we have implemented the process and how we're going to evaluate the impacts of this process in real time and how we're going to respond to any changes that we need to make in the implementation, any changes we need to make in the education component of it, so that we can go along and we can fully implement and optimize this program for the clinic. We've seen this before in previous modules, but to bring it back again, this is the general process that we want to see followed from start to finish after we have integrated all of the individual components of this project. This is the overall general flow that we want to see, in that we want to use the ACMA standards that are out there and the NTOC standards that are out there, and how we integrate those into the process themselves. And just to remind ourselves that kind of the difference between the NTOC and the ACMA standards, again, the NTOC have the 7 essentials and they focus kind of more of an intra-facility focus, so from one point to another, where the ACMA instead focuses from intra-facility processes, from provider to provider, provider to intra-facility resource, and how that gets disseminated if there's an outside referral to another provider or specialist. And what we can do is we can take our general process flow and integrate and plug in where the NTOC and where the ACMA all come into play. As you can see, the NTOC is kind of like in the beginning part of this process flow, and then the ACMA takes over as the patient's integrated into the service lines and resources that are available within the clinic itself, and how that takes us through to the end of that 30-day post-discharge period, to where we reevaluate. And if we've had a readmission in between there before we get to day 30, day 28, then that process starts all the way back at the beginning with the NTOC, the hospital discharge, and we go through it again, and then we reevaluate as well. We do a root cause analysis to find out if it was on our end, if there was something that we didn't do that we need to change to prevent a patient from going back in, if it was an avoidable readmission, if it was an unavoidable readmission. Now we just add that piece into the current process. We start back at day 0, add that part into the patient resources, and continue on again for another 30 days within this program. Let's drill down and take an even closer look at NTOC and the ACMA standards and where they really do influence and really do come into play. So this is that first part of our generalized process flow. So this is getting ready, not even at the discharge point, we're getting ready for that discharge point. The patient's still in the hospital at this point. We haven't even gone to the discharge. Patient hasn't even stepped foot into the clinic for their follow-up appointment yet. And this is a really good area diagram that shows that overlap that has to happen between the hospital and the clinic, and how vulnerable that patient is at falling through the gaps of care at this point in that care continuum, and why we need that overlap. So before the patient is even ready for discharge, the hospital needs to complete their transitions assessment, do medication reconciliation, educate the patient, make sure that follow-up appointment is scheduled. And the bulk of the NTOC essentials fall here. Essentials 1, 2, 3, 5, and 6, as you can see, really hone in on this segment here, but then they also carry through to that clinic follow-up phone call appointment after discharge, and then also come back into play again, where they overlap with the ACMA standards at the beginning of that follow-up appointment. So you see there's a lot of overlap, and that's intentional because this is one of the most vulnerable points, again, of that patient, where they can fall through the cracks very, very easily, get lost in that shuffle, and end up going back to the emergency room, getting admitted back to the hospital, just because even though there might have been a handoff from one entity to the other, wasn't cohesive enough to carry that patient through until you could physically see them in the outpatient office. Also, again, in this point, this is where the information transfer comes into play, and it's in two different forms of information transfer. So the first point where Essential 4 comes into play is that transfer point where the information is going from the hospital to the practice. But then after the initial phone call, that information is going from one person in the practice to another person in the practice. And that's important because you can still lose information, particularly if it isn't placed in an organized fashion, if it isn't put in one specific area where everybody knows to go look for and retrieve that information, or that information isn't even there to begin with. So how can you have an adequate appointment with your patient if you don't even have that information available to review cohesively and effectively right there in the time when you're supposed to be making these goals? You're supposed to be evaluating the patient for the next steps in their plan of care. And then you can see at the bottom here, shared accountability goes fully across that continuum. Both facilities have shared accountability for this patient and for this handoff. So this is where that overlap between both facilities come in, making sure that that patient gets to where they need to be when they need to be there. And then you can see Essential 5, follow-up of care, comes in at every single point of contact with that patient, whether it be with the hospital or whether it be with the clinic themselves. So important. And then we can follow that through to that follow-up appointment. And this is where the ACMA standards begin to influence that patient care and patient direction. So the first three standards, ACMA 1, 2, and 3, where we identify patients at risk for poor transition. So we're doing that chart abstraction and risk stratification, complete a comprehensive transition assessment, perform and communicate medication reconciliation. A lot of this stuff will be done during that initial phone call. And really, it should not take very long because this stuff should be done prior to the patient's discharge from the hospital. So it's a matter of getting that information that stuff that was already done to the clinic staff. And it's a matter of reviewing that information with the patient, making sure that it's still true and accurate, and then passing that along to the provider and the care management staff. If you don't have that component done, or if you cannot access that, you're redoing all of this work that was already done beforehand. You're reinventing a wheel that's already been produced. You're aggravating the patient, you're doubling services, you're creating inefficiencies within the system. And so therefore you're costing your clinic more on the back end by repeating all the services that have already been done. The next thing with this patient flow is where you have your patient actually there in the office for the follow-up appointment, and your navigator and your primary care provider are both going to see the patient in this visit, and you're going to approach them and say, hey, you are eligible, you meet criteria for certain services. Are you interested in being part of this transitions of care program to help you get services on an outpatient basis so you don't have to keep going to the hospital for the same thing that we can be providing for you here? And that fourth standard, establish a dynamic care management plan that addresses all settings throughout the continuum of care. So you've got all this information, you've got the players here with the patient at the same time, and you're developing this. And note that this appointment takes an hour total, actually an hour and 5 minutes total, 65 minutes to go through all of this information. This is a long time because there's a lot of information that you need to address, and there's a lot of things that you need to set the patient up for while you have them there in the office face to face. And then once you have the patient on board with this, you've established goals that everybody agrees with that needs to be done. Now you can communicate this to the rest of the transitions of care team, and you have 3 different options. You either have just a referral for a community navigator for just community services if that's needed. You have care management follow-up with or without nurse practitioner TCM services, or you don't have any additional care management services, but you get them set up with referrals and get them appointments with specialists that they need to follow up with, and identifying any barriers that would prohibit them from attending those appointments. And then making sure that information gets back to the primary care team and get the patient back to the primary care team as well, so they can continue that management outpatient without risking your patient having to go back to the emergency room or get admitted back to the hospital because they, again, fell through those cracks along the continuum of care. This is just some additional core responsibilities and metrics according to the ACMA. So we talked about before in one of the other modules where the ACMA has established within these 5 essential guidelines or standards that by meeting these standards, you're also meeting different CMS measures, different KHEPS measures, different HEDIS measures as well, and that you can track these and you can report these for additional funding through CMS and billing through CMS. What these next few slides show is who's responsible for these different standards, for meeting these different standards. And by meeting these different standards, this person is going to be meeting these different measures and metrics that are tracked by these different agencies and different reimbursement avenues of reimbursement and things like that for your patients or for your clinic. So, and what these do here, so notice that the RN has a big role to play in meeting these goals. Your community navigator has a lot of these goals because you're making sure that your patient is getting to where they need to be, and then all of these different processes are coming together and they're being utilized properly. But that's not to say that other people have that don't have responsibilities either. Your pharmacist has a bunch of responsibilities as well in meeting these standards for the ACMA transitions of care standards, and ultimately meeting these different core measures as well. Some of these can be delegated between your primary care provider and your nurse if that is necessary, if you don't have a pharmacist. But if you do have a pharmacist, you can delegate some of these tasks and responsibilities to that pharmacist. And the other thing that is potential here is your pharmacist now can also bill for these services incident to your primary care provider, whether they be a physician or even a PA or NP, if they're the primary care provider for that patient. So there's still, your pharmacist isn't left out of being able to get compensated for the extra time and effort that they're putting into this. There is that ability for them to bill and get some compensation for the time that they're putting into reviewing these charts and giving their feedback and professional recommendations on management of pharmacology optimization for these patients. And of course, your primary care physician has responsibilities as well in regards to obtaining these standards from ACMA and these core measures. But also, though, there's two other people that may be forgotten that have a distinct role in the ACMA in the transitions of care program and ultimately the ACMA standards is your QA/QI officer and also your scheduler. They have a bunch of responsibilities as well. So you see, this is a very vast and complex team, a comprehensive team. And that doesn't even talk about your care managers, your community navigators, your other education staff and other personnel as well. Any dietitians that you want to bring on staff to be a part of this program, that doesn't account for them either. This is just the core staff meeting those core measures at the most basic level. So this is all well and good. However, this is just the results based on the review of the literature and combining everything together in this standpoint. But going back again to our fishbone diagram that we saw at the beginning of this presentation, this is only a small chunk of what we need to address with developing this project and creating this into its own evidence-based practice standard. And in order to do that, we need to take some time and we need to look at the gaps in themes that are already present in the current clinic practice. And in order to do that, a site survey was completed, and it was a 3-day, spread out over 3 days, looking at interviewing, sitting down with staff, observing what everybody does, looking at how the appointment flow goes, and coming up with reviewing all the notes, and then looking at all the gaps, looking at the themes that developed between both the nursing staff and the providers. So this is going to inform what areas are working well already within the stuff that we've identified that are components of a functional TCM program, and what areas we really need to focus in and concentrate on to really bring this whole package together to have a full and cohesive implementation. And as you can see here, there's a lot of different things that were identified, barriers to obtaining care, things of that nature as well. The transient nature of patients, trouble with phone follow-ups, and we looked at both nursing and providers, two different things. And what this also came into play was with perception as well when we looked at patient satisfaction and staff satisfaction. So this is the PSQ 18. It's an evidence-based patient satisfaction survey that was developed. It was based off of a larger survey called the PSQ 3. So this took the PSQ 3 and boiled it down to 18 different questions that was broken into several different subcategories. And this was administered over 2 weeks, a 2-week period of time to the patients in the clinic. And what we found was that there was overall low satisfaction in the care of the patients that they were receiving through the clinic. However, what ranked high was the interpersonal manner and the communication of the patient between the provider. However, these visits weren't very substantial. And you can see that in the response: time spent with doctor, accessibility and convenience were not rated very high by the patients. And that can be explained partly through the thematic and gap analysis that was completed, that we already knew going into this that the information retrieval was very low, so that there was a need to be able to have this program incorporate information retrieval and chart abstraction before the appointment, so the providers had some idea of what to do with these patients when they were here in the clinic. The staff knowledge and perception kind of also went in tandem with this. And this is very interesting though. So the staff reported that they perceived patient satisfaction to be very low, which is very accurate. However, the staff were satisfied though with the processes that were currently in place. And this makes kind of sense because looking back again at the thematic analysis between the providers and the nursing staff and ancillary staff that was done during that 3-day period, a lot of the feedback that was obtained showed that the staff perceived they were doing things as much as they possibly can, but that there was a problem with the patient on the patient side of things. And that was where the dysfunction of the program and the process lied, was on the patient and not with the staff or the process itself. There was very low knowledge of the transitions of care program, what it is, what it was meant to do, what the purpose of the program was. So that tied into the goals of the Kirkpatrick model, what we needed to focus on for outcomes with that model when we utilize that to evaluate the type of education that we were going to implement as well. And all of this played into the overall implementation plan and objectives that was developed, looking at the gap analysis, looking at the literature that was reviewed and developed, and looking at the themes and the gaps, and then also looking at the results of the staff surveys. So our outcomes were identified to have follow-up appointments, to discharge summaries and information transmitted consistently, proper risk stratification, goal setting, reduction in 30-day all-cause readmissions, spending, the cost-benefit areas of it, efficient workflow, increased patient attendance, and also thereby increasing patient satisfaction with the services that they were received at the clinic. And all of the outcomes, all of the benchmarks for the different outcomes were based upon what was reported as feasible by the literature that was reviewed. The one final piece that we needed to do following our Ottawa model to have all of the components necessary to develop this model and have it all set for implementation was then the cost benefit, the predictive cost benefit analysis. And this was following the guidelines published by A et al. And what we looked at was both the potential societal cost on having a transitions of a care program, and then also what it would cost the clinic and what they would get back in terms of reimbursement, and where that money would be coming from in terms of reimbursement. So let's look at the society cost and reimbursement first. So overall, this model, the transitions of care model, showed that there would be significant cost savings upwards of $18.4 million a month to the overall health system and society with the implementation of a transitions of care program. Let me say that again, $18.4 million a month, utilizing both APPs and MDs combined. So each would save roughly at the highest bit, so 41% reduction in readmissions. Between both APPs would be around $9.2 million a month, physicians $9.2 million a month, combined again, $18.4 million a month in savings to the health system in general, with costs of providing care. And again, all of these cost savings were utilizing the previously identified short-term, intermediate, and long-term goal benchmarks from our outcome table that we just saw on the previous screen. One thing interesting that was noted with this was looking at the number of visits per month between providers, between APPs and physicians, what we were using. They far exceeded the number of actual visits that were completed per month by the patient panel. So 280 readmissions a month. However, their average visits per month for APPs was 511 visits. So this also not only identified cost savings and cost expenditures, but also identified where the expenditures were coming and the inefficiencies related to the expenditures. So the next step, what we did with the cost benefit analysis, was to look specifically at the clinic and look at it from a more efficient standpoint. So saying, for example, if we only had only those 280 visits a month, and we only made it 280 visits a month, the actual number, we took out that 511, and we only have the number of visits of patients that were actually having like admitted or readmitted to the hospital, there's a significant amount of savings. So these numbers initially, all these numbers are based off of that 511 for visits for APPs and 48 visits a month for MDs. So overall, even though with those numbers, if we still kept the 511 visit rate, we're still seeing total savings of $80,000 to $98,000 up to almost $120,000 a month of just savings. After expenditures are accounted for, you're still banking between $23,000 and $35,000 a month. After all the costs, when you consider your primary care providers, your transitions of care staff, including your care management worker and your nurse practitioner, you're still making upwards of $35,000 a month from largely cost avoidance. You are breaking even, you are making a little bit of money, you're at least breaking even when you're considering reimbursement. But again, your big revenue is based solely on cost avoidance and making a more efficient system. So now your patients aren't being cared for, and they aren't having this transitions of care track being done by your primary care staff. They're being shifted over into a different panel temporarily, so that your providers, your primary care providers, can still see other patients on their panel, but your transitions of care patients are still being taken care of and being supervised by a provider, at least at the APP level, while they're in this 30-day transitions of care program. It's very important. The other thing to look at with this predictive analysis that was done is this shows that there is that ceiling effect of reduction where you're making money, but then you go over and now you're starting to lose money again. So this gives us an idea of a target of where we want to kind of shoot for, what's going to maximize both reduction in terms of reduction and also maximize in terms of how many patients you have in the service, how many patients you have on the panel. Now, the more patients, again, that you have in your transition of care panel, you can start outweighing your cost avoidance with reimbursement. So there's other things that you can funnel in. CCM services weren't considered in this. Patient monitoring services weren't included in this just because of they're additional, and they have several different requirements that go along with this. So you still have a couple other avenues of billing that weren't accounted for. However, though, again, you have to keep in mind that a lot of these billing costs have to be delayed that 30-day post-discharge period to satisfy that there has been no readmissions within 30 days that would have been considered avoidable by CMS. But it still is very promising. This is still, worth discussion, and a very arguable point that you can still make money with this service line, even with the intensity of services that you are providing to your patients that are enrolled in this program. So with that, we come literally full circle, and we have developed that EBP standard that we can now implement into the clinic practice and the current process flow of the clinic, and start utilizing our evidence-based methods, our IHI, rapid cycle process change. We can start for evaluation. We can start utilizing our Kirkpatrick model for evaluating our education, if it was effective, and making adjustments and making further education points as we need. However, though, this is a very complex process, and it takes a lot of different things coming together in one cohesive package to be able to even get to this point, to even begin to think about starting to implement this into your daily practice. However, what I've been able to do in this presentation is show you that it is possible, it is feasible, and that there is a standard that is now developed that can now be implemented into the practice, that is based within reasonable real-life data, and that has been confirmed through evidence that has already been published and available. And with that, I thank you for your attention. And what you can do now, go ahead, once again, pick up your cell phone, open up the camera on your phone, point it at the QR code, tap that link that pops up, and complete that survey so that we can get feedback on the content of this presentation, and that we can follow our own Kirkpatrick model, and that we can adjust and increase the effectiveness of our education delivery for transitions of care. Thank you again for your time, for your patience, and for your feedback. Thank you very much.